Imagine a pain so severe that your brain essentially um, builds a muscular fortress to protect you from it.
Yeah, and we really aren't talking about a metaphor here either.
Right. For thousands of women, this is a daily, excruciating physical reality. And it's caused by a tiny band of tissue that pop culture has just completely and unfortunately misunderstood.
It's one of those medical realities where, a tiny anatomical variation just spirals into something that can take over a person's entire life.
Absolutely.
Because we like to think of human anatomy as predictable, right? That things will stretch or yield when they're supposed to. But when a natural mechanism fails to yield, the resulting cascade of physical and psychological defense mechanisms is profound.
And that is exactly our mission for this deep dive. Today, we're taking a massive stack of sources. We've got medical clinic guidelines, peer-reviewed surgical case reports, and gynecological research papers.
It's a lot of material.
It is a ton of material. And we are going to completely demystify the hymen. But more than that, we are zeroing in on the incredibly precise surgical protocols used when an abnormally thick or rigid hymenal ring causes what the medical literature calls intractable entry dyspareunia.
Which is quite a mouthful.
It really is. And if you're hearing that term for the first time, it's basically just the clinical way of describing severe, unyielding pain during attempted sexual penetration. Okay, let's unpack this.
Yeah, let's get into it.
Because for you listening, this deep dive is going to separate centuries of cultural myth from modern medical reality. We're going to give you a really fascinating look into a highly specific, life-changing surgical intervention.
And to really understand the surgery, we have to strip away the misunderstanding surrounding the anatomy itself.
Right.
The hymen is not what pop culture or, historical myths tell us it is. It's not some kind of freshness seal that covers the entire vaginal opening just waiting to be broken.
Right. And the World Health Organization guidelines are incredibly explicit about that.
Oh, absolutely.
They state as a matter of medical fact that the appearance of a hymen is absolutely not a reliable indicator of past sexual intercourse. It isn't a viable metric for that at all.
Precisely. A typical hymen is simply a thin, stretchy, half-moon-shaped membrane located at the vaginal opening. It naturally has an opening to allow menstrual blood to exit the body.
Which is pretty important.
Very important. And over time, it stretches and changes from completely mundane activities, riding a bike, doing gymnastics, using a tampon, or just the natural estrogen changes that happen as a woman's body develops.
Yeah, it naturally adapts.
Right. All of these affect its shape. Furthermore, it has very few blood vessels. So the pervasive idea that it always inevitably bleeds during first intercourse is a fundamental misunderstanding of the actual tissue.
But as with literally all human anatomy, there are congenital variations, right?
Exactly.
In the UK alone, these variations affect thousands of women. You've got septate hymens, which feature like a band of extra tissue straight across the middle.
Yeah, like a bridge almost.
Right. And then you have cribriform hymens, which look almost like a sieve with a bunch of small holes.
Yep.
There are microperforate hymens, which have just one tiny hole. And then there's the imperforate hymen, which completely covers the opening and traps menstrual blood.
Which occurs in about 0.014 to 0.1% of newborn females. And that one is an immediate medical emergency when puberty hits.
Wow. Yeah. But for this specific deep dive, we're looking at a variation that is a bit more insidious, I think.
It is, yeah.
Because it isn't necessarily completely closed. It's just abnormally thick, rigid, or inelastic.
And that rigidity changes the entire mechanical reality of the pelvis.
How so?
Well, most hymens are pliable, but when that tissue develops as a thick, fibrous band, it just refuses to adapt.
I like to think of a normal hymen like a flexible air scrunchie,
That's a great analogy.
Right, it's designed to stretch, accommodate, and snap back. But a rigid hymenal ring is like a thick, heavy-duty plastic zip tie. If a woman with this zip tie anatomy attempts intercourse, or even just tries to insert a tampon, it won't give. What is actually happening at a microscopic level when pressure hits that rigid band?
What's fascinating here is how the body's neurology interprets that mechanical failure.
Okay.
When pressure is applied to that rigid tissue, The nerve endings in that localized area are suddenly subjected to these intense, concentrated stretching forces that they physically cannot accommodate.
So they're just getting pulled way too hard.
Right. It isn't just uncomfortable, it's a localized trauma. The tissue is essentially tearing at a microfiber level without actually giving way.
Oh, wow. Ouch.
Yeah, and those stressed nerve endings fire off immediate, urgent pain signals to the brain. It creates a burning, tearing sensation that makes penetration physically impossible and, quite frankly, psychologically terrifying.
Which brings us to the cascading effect of this. Because the pain is so intense, it isn't just a physical barricade anymore, is it?
Not at all.
The brain steps in and creates a muscular fortress to protect that zip tie.
It creates a brutal negative feedback loop. The body is evolutionarily hardwired to protect itself from trauma.
Right.
When a woman experiences that level of pain at the vaginal opening, the nervous system remembers. It triggers a secondary condition called vaginismus.
Vaginismus, and
It's the involuntary reflexive spasming of the pelvic floor muscles in anticipation of pain.
so it's an autonomic flinch, basically, but dialed up to 11.
Exactly.
Your brain senses a threat approaching an incredibly sensitive area and just locks the entire muscular structure down to prevent further injury.
That's the perfect way to describe it. The rigid hymen is the physical trigger. But over time, the anticipated pain carves a deeply ingrained neurological pathway.
So it becomes a habit for the muscles.
Yes, the muscle spasm becomes an automatic response. At a certain point, even if you were to magically remove the rigid hymen while the patient was sleeping, her pelvic floor muscles would still violently spasm at the mere thought of penetration,
Wow.
because that fear-pain pathway is so deeply entrenched.
So what does this all mean for a surgeon trying to fix it? Because if you have a physical zip tie, but you also have this muscular fortress aggressively guarding the zip tie, a misdiagnosis seems incredibly easy to make.
Oh, it requires a highly nuanced clinical approach because doctors have to differentiate between purely psychological primary vaginismus and secondary vaginismus that is being caused by a physical abnormality.
Like the rigid ring.
Right. Let's say a surgeon assumes it's just a tight opening and performs a Fenting's operation.
Which is what, exactly?
It's a standard surgery to enlarge the vaginal opening.
Yeah.
If the core issue is actually the muscular spasm of vaginismus, that surgery is completely useless.
Oh, I see.
Yeah, you've cut healthy tissue, but the muscles underneath are still violently spasming. However, when a rigid ring is identified as the physical root cause driving the muscular spasm, modern medicine has developed a combined approach that is nothing short of revolutionary.
And the clinical audits on this combined approach show a staggering 91 to 92% success rate.
It's really incredible.
They achieve this by combining a hymenectomy, which is the physical removal of the tissue, with Botox injections. Now you hear Botox and immediately think of Beverly Hills dermatologists freezing forehead wrinkles, but it's actually heavy-duty neurotoxin, right?
That's right.
How does that work in the pelvic floor?
Exactly. Botulinum toxin is a powerful paralytic. When the surgeon injects Botox directly into the spasming pelvic floor muscles, it blocks the release of a neurotransmitter called acetylcholine at the neuromuscular junction.
Faithful choline.
And without acetylcholine, the muscle fibers simply cannot contract. They are chemically forced to relax.
Wow, so it completely short-circuits the neurological fear spasm cycle.
It really does. Then, while that muscular fortress is temporarily paralyzed and out of the way, the surgeon can perform the hymenectomy to remove the physical anatomical barrier. You know, that rigid zip tie?
With the muscles chemically relaxed and the zip tie gone, the recovery is remarkably fast.
Yes, it is.
Patients are sent home with vaginal dilators to use for 2 to 4 weeks. Because the Botox keeps the muscles from spasming, the brain finally experiences touch without pain.
They essentially reprogram their nervous system.
That's amazing. The audits note that the majority of patients achieve totally pain-free penetration after just 3 to 6 attempts with the dilators.
It is a profound restoration of a patient's quality of life. But we can't gloss over the surgery itself.
Now let's get into it.
The physical removal of that barrier, the hymenectomy or hymenectomy, isn't just a simple snip. It is a highly refined surgical protocol that requires serious precision.
So if Botox handles the muscular fortress,
Right.
you're still left with that physical zip tie. You can't just leave it there.
No, absolutely not.
How are surgeons actually removing it without causing a ton of scar tissue that just acts like a second zip tie?
To start, this is an outpatient procedure, usually taking 15 to 40 minutes under local anesthesia or light sedation.
Okay, pretty quick.
Yeah. When we look at the actual technique, there are a few distinct approaches depending on the specific anatomy. The most common traditional approach is the cruciate incision.
Cruciate meaning cross-shaped.
Yeah.
Or sometimes I call it a stellate star-shaped incision, right?
Yes. The surgeon makes an X-shaped cut into the rigid hymenal tissue, but they are incredibly deliberate about where those cuts are made.
Where do they put them?
They specifically make the incisions at the 2, 4, 8, and 10 o'clock positions on the ring.
Okay, let me visualize the anatomy here. The urethra, where urine exits, is sitting right at 12 o'clock above the vaginal opening.
Right.
And the rectum is directly below at 6 o'clock. So by cutting at the diagonals at 2, 4, 8, and 10, they are steering completely clear of the most critical surrounding structures.
It is pure anatomical risk management.
That makes total sense.
Yeah, and once those diagonal cuts are made, the 4 quadrants of excess rigid tissue are meticulously excised or, cut away. Then the mucosal margins, which are the inner edges of the remaining tissue, are folded back and stitched to the vaginal vestibule.
What kind of stitches do they use?
They use fine delayed absorbable sutures, usually something like a 3/0 Vicryl,
Oh, okay.
which hold the tissue in place while it heals and then naturally dissolve over a few weeks.
But the research highlights a modern evolution of this, because that traditional X-cut, as careful as it is, carries a risk.
It does.
Sometimes the scarring from those 4 incisions contracts as it heals, which can actually reclose the opening, creating what's known as a stricture.
And that stricture risk is exactly why a modern case report advocates for what's called an annular hymenectomy.
Annular, meaning like a ring.
Yes. Instead of using scissors or a scalpel to make 4 cuts, the surgeon uses electrocautery, which is a heated surgical instrument, to make a circumferential or ring-shaped excision.
Oh, wow.
They completely remove the entire rigid tissue band in one continuous circular motion.
So there's no flaps to fold back.
Yes. Exactly. And because the electrocautery tool uses heat, it instantly seals the capillaries as it cuts. This drastically reduces bleeding and limits the intense inflammatory response that usually leads to thick, fibrous scar tissue.
That makes a lot of sense from a tissue healing perspective.
Yeah.
But there is another highly specialized procedure we need to get into called the Donders widening plasty.
Yes.
This is deployed for a very specific variant of this pain called central introital dyspareunia, or CID.
Which is when the excruciating pain is intensely localized right at the 6 o'clock position, the very bottom edge of the hymenal rim.
Right.
CID is notoriously stubborn, and the Donders plasty is fascinating because it is a non-excisional widening plasty.
Meaning they don't take anything out.
Exactly. That means the surgeon isn't actually cutting any tissue away to remove it. Instead, they make a longitudinal cut, slicing straight down vertically through the hymenal border and deep into the underlying muscle. Then they separate the mucosal lining from the skin and stitch them together transversely or horizontally.
Okay, here's where it gets really interesting and honestly highly counterintuitive.
Yeah, I know where you're going with this.
If you have a patient whose entire problem is agonizing pain during penetration, how on earth does taking a scalpel, cutting vertically down through the vaginal tissue and the underlying muscle, and then stitching it back up sideways, actually stop the pain of dyspareunia? Doesn't cutting muscle just create a harsher, thicker scar?
It seems completely backwards until you look at the structural engineering of the tissue.
Okay, explain that.
To understand it, go back to your zip tie analogy. The pain of CID at that 6 o'clock position isn't caused by the mere presence of tissue. It is caused by the extreme tension of that tissue.
Ah, it's too tight.
Yes, that specific rim is pulled entirely too taut. By cutting vertically through the muscle and then suturing the tissue horizontally, the surgeon is artificially creating slack.
Okay, I'm visualizing that.
They are effectively snipping the tight zip tie, adding an inch of extra material to the loop, and taping it back together. It gives the vaginal opening the exact amount of slack it needs to stretch naturally without tearing.
Wow.
The resulting scar is actually wider and looser than the original rigid band ever was.
It's quite literally structural engineering applied to human biology.
It really is.
But shifting gears entirely, it's worth noting the cultural realities that intersect with these medical emergencies. In several global traditions and communities, an intact hymen is a strict, non-negotiable prerequisite for marriage.
Yeah, this is a very complex area.
It is. It's viewed as incontrovertible proof of virginity. And a woman lacking it can face severe, life-altering social ostracization.
Which creates a massive ethical and medical dilemma for surgeons.
Absolutely.
If a young woman from one of these communities presents with a rigid or imperforate hymen that is causing her immense pain or trapping menstrual blood. How does a surgeon resolve the medical emergency without destroying her social standing and safety?
Right.
Medical research has actually developed a deeply specific, conservative protocol for this exact scenario.
Right. Instead of a cruciate excision or a full annular removal, the surgeon makes only a very small, central, oval incision.
Correct.
But then the protocol calls for inserting a 16 French Foley catheter through that tiny opening. Now, a Foley catheter is a medical tube with a small inflatable balloon at the tip. They inflate this balloon inside the vagina and leave it there for 2 weeks.
Yeah, it sounds intense.
Wait, why are they leaving an inflated balloon inside a fresh incision? Doesn't that just violently stretch the exact tissue they're trying to let heal?
It acts as a stent, but a highly controlled one. The inflated balloon doesn't stretch the outer perimeter. It just holds the central opening pattern, meaning it keeps it open so trapped fluids can drain.
Oh, I see.
Critically, by only keeping the center open, it preserves the outer annular intact shape of the hymenal ring. But the key to making this work without causing massive scar tissue from the balloon's pressure is the application of topical estrogen cream.
I noticed that in the protocol. How does estrogen cream help a surgical wound heal?
Well, estrogen binds directly to receptors in the vaginal mucosa. It actively promotes cellular turnover, increases local blood flow, and accelerates collagen synthesis.
So it supercharges the healing.
Basically, yeah. By flooding the surgical site with estrogen, the tissue thickens and heals rapidly around the catheter. When the balloon is finally deflated and removed after 2 weeks, the patient is left with a small, functional opening that resolves the medical crisis while leaving enough of the hymenal rim intact to assure her family that the cultural requirements are preserved.
It is an incredibly pragmatic adaptation of medical protocol to navigate a deeply complex social reality.
Very much so.
But regardless of whether a patient gets a full annular excision, a Dyspareunia, or a conservative stenting, the surgery is just the first step. The tissue still has to heal, and the recovery protocols are intense.
The post-operative instructions are incredibly strict to ensure these delicate, tension-bearing sutures heal correctly.
What do they involve?
Immediately after the outpatient surgery, the patient remains in the clinic to rest for 1 to 2 hours. For the first 24 hours at home, there is absolutely no driving, no drinking alcohol, and no heavy lifting.
And strictly no aspirin. Aspirin is a blood thinner, and given how vascular the deeper pelvic tissues are, thinning the blood can cause a severe hemorrhage at the surgical site.
Exactly. Pain management is strictly limited to acetaminophen or specific prescribed analgesics.
Okay.
After 2 days, patients are instructed to take warm sitz baths. This involves sitting in a few inches of warm water several times a day. The warmth causes vasodilation, which is widening the blood vessels, which floods the area with white blood cells to prevent infection and speeds up tissue repair.
That sounds soothing, at least.
It is. And crucially, absolutely nothing goes into the vagina. No tampons, no dilators, no intercourse for 2 to 6 weeks, while those absorbable sutures dissolve and the tissue fully fuses.
Which brings us to the long-term data on this healing process. There was a massive 10-year study on the Donders widening plasty we discussed earlier, following over 500 patients.
A very significant study.
The good news is the surgery is highly effective.
Yeah.
It fully resolves about 75% of the localized pain problems. But the timeline is a massive reality check. Patients have to be explicitly warned that it can take 1 to 2 years to achieve the maximum effect and return to entirely normal sexual activity.
Wow, yeah. Healing mucosal tissue is one thing, but healing inflamed nerve pathways and completely overwriting years of muscle memory takes significant time.
2 years is a long time.
It is. The nervous system has to unlearn the trauma. But speaking of the nervous system, that same Donders study ran a multivariate analysis on the patient's recovery that produced some truly bizarre data points.
Oh, I know what you're referring to.
They tracked various lifestyle factors to see how they impacted post-operative pain during intercourse. Unsurprisingly, they found that highly anxious women suffered far more pain during their recovery, as anxiety directly correlates to pelvic floor tension.
That tracks perfectly. If you are anxious, your muscles are clenched.
Right.
But the other data point, well, doctors universally tell you that smoking ruins surgical recovery. Nicotine is a vasoconstrictor, right? It shrinks blood vessels and literally starves healing tissues of oxygen.
Yes, typically that's the rule.
But this study showed that smoking women actually recovered better from this specific surgery. They reported significantly less pain during intercourse post-op. Wait, usually doctors tell you smoking ruins surgical recovery. Why on earth would smokers fare better here?
If we connect this to the bigger picture, the study itself notes this as an unclear reason from a purely biomechanical standpoint.
Right.
From a vascular perspective, smoking absolutely should impede healing. However, nicotine is a highly potent psychoactive substance that heavily impacts the central nervous system.
Okay, so the brain thing.
Yeah. It acts as an anxiolytic. It temporarily reduces psychological anxiety and fundamentally alters pain perception in the brain. While the researchers don't definitively rubber stamp this explanation, this bizarre anomaly highlights just how deeply intertwined psychological anxiety, physical tissue healing, and the subjective perception of pain truly are.
It proves that treating intractable dyspareunia isn't just about mechanically cutting tissue. It is about treating the entire nervous system.
Precisely. You can surgically engineer the mechanics flawlessly, but the brain's interpretation of those mechanics is what ultimately dictates the patient's lived reality.
So if you take anything away from this deep dive, let it be this. A thick or rigid hymen causing excruciating pain is not a psychological failing.
No, not at all.
It is not all in a patient's head, and it is certainly not a permanent life sentence of pain. It is a highly specific mechanical issue. It's a biological zip tie that simply failed to yield.
Perfectly said.
And as we've seen, modern medicine has developed highly refined surgical protocols, from cruciate incisions that carefully map around the urethra to Botox combinations that chemically disarm fear-driven muscles, all designed to meticulously remove that physical barrier and restore a patient's quality of life.
This raises an important question, though, one that sits right at the edge of everything we've explored today.
Oh.
Throughout this deep dive, we focused on the hymenectomy, a medically necessary surgical protocol designed to open rigid tissue and liberate a woman from agonizing pain. However, the medical literature also details the existence of a booming global cosmetic industry for hymenoplasty.
Which is highly controversial.
Very. Organizations like the UK's Royal College of Obstetricians and Gynecologists are actively trying to ban it.
And to be clear on the clinical definition, a hymenoplasty involves a surgeon intentionally creating artificial scar tissue at the vaginal opening. The sole driving purpose of this surgery is to guarantee that a woman will bleed on her wedding night, thereby proving her virginity to a partner or a family.
It is the exact literal inverse of the hymenectomy. We leave you with this paradox to ponder on your own. How fascinating and perhaps how deeply troubling is it that the exact same surgical tools and anatomical knowledge of modern medicine are simultaneously being used to surgically remove hymen tissue to liberate women from physical pain and to surgically construct artificial hymen tissue to bind them to a cultural myth?
It's a heavy, complicated thought. Medicine has finally perfected the tools to remove the unyielding locks on human anatomy. The question we have to ask now is, why are we using those exact same tools to install artificial ones?
A question well worth diving into.